again, everybody, and welcome to another edition of Doc Talk with Monument Health. My name is Mark Houston, and joining me today is Dr. Kenneth Milligan, an orthopedic surgeon, new-ish orthopedic surgeon at Monument Health, right? Glad you could come up here, Doctor. I appreciate it. But where did you come from? How did you end up here?
Yeah, so thank you for having me on
absolutely.
First. I've been here for about 4 months now.
Okay.
I came from Columbus, Ohio most recently, but I'm actually not too far away from Denver, Colorado. Is where
really?
I kind of grew up and did most of my training, and then I did another half of my training out on the Northeast.
So you're used to all of this kind of weather that we're about to have out here too, then. None of this will surprise you.
Yes, no, this is all completely very familiar to me. I was telling my wife that
Do you do outdoor sports? Do you do anything like that when it gets cold?
Yeah, so growing up in Colorado, I kind of did a lot of the typical things. I'm big with backcountry skiing and skiing in general.
Oh, no kidding.
And then climbing and also just kind of like hiking and mountain climbing, just being in the mountains. So.
Well, and what's for people that may not have heard the beginning of this, you're an orthopedic surgeon. So everything you're doing is dealing with hips and knees and shoulders and stuff that eventually will wear out on us, right?
Yes.
How did you pick this particular field, though?
Yeah, so I actually came to this field a little bit different than probably even most orthopedic surgeons or even most physicians. I actually started with pursuing kind of in undergrad, pursuing a career in mathematics and actually like going to university to become a physicist.
Oh, wow.
Yeah, and then...
Well, at what point did you realize... Nah, I want to cut somebody open, and I want to fix that.
Yeah, so I kind of tell the story. I was doing physics research for a while, and in doing that research, we were actually studying these little small semiconductors called quantum dots, and they emit a light, and so to measure the light that they emit, you have to be in the darkest room available, and we were kind of doing those experiments, also combined with this special microscope that any kind of sound will disrupt it, and so it also has to be the quietest room possible. And so I was on the campus in the darkest, most quietest room in all of our university, and decided that I needed to figure something else out.
You wanted a little more interaction than
Yes.
that? God, that's my dream, though, right there. Just that dark, quiet room.
It's nice, but once you start doing that for like 10 hours a day or more,
mentally it's got to mess with you a little bit.
Yeah.
So does having a physics background like that, does that play into a practice like being an orthopedic surgeon too? Are there parts of it that really help you when you're in this procedure?
Definitely. I mean, I do a lot of revision total hip, and so especially in that situation, there are a lot of mechanical things that have either went wrong, that we need to, one, try to diagnose what's going wrong, either mechanically or, if there's something biologically, that as well, but then also fixing it and reconstructing that. And so there's a lot of mechanics and biomechanics in that. And I actually ended up in medical school doing a master's in bioengineering and focusing on biomechanical modeling. So
wow.
Yeah.
All right. Well, let's get into a little bit about specifically then kind of what we want to talk about today, which is kind of hip and knee in general, right?
Yes.
So first signs that something is wrong. What generally happens to people that will get them to think, all right, now I've got to visit a doctor? I mean, what are those little things people look for in the hip and in the knee that lead them eventually to you?
Yeah, so the hip and the knee, I think, are a little bit different in the way that they present. In particular, for the hip specifically, it doesn't necessarily always present with pain on the outside of the hip where you kind of think, hey, this is my hip, or where you kind of grab to. A lot of times it can present as growing pain. And so you'll say, oh, I have, pain in my groin when I'm sitting for long periods of time. Or you notice it getting in and out of the car or bending down, putting on your shoes and socks. So those are kind of some of the typical things that patients may notice. And it may not even be a sharp pain. It may just be kind of a dull ache that gets worse and worse. And we can even see patients who really never endorse pain, and yet they have a quite noticeable gait disturbance or a limp, and everyone around them sees them limping around, and they're like, oh, it kind of hurts, but not too bad.
Yeah.
And when you replace their hip, actually, they really notice a big difference afterwards, just because I think the slow, insidious onset of the pain allows you to accommodate to it a lot better than the knee per se.
So, okay, then go to the knee. What would you recognize, or what would people start to notice there? Because it seems like all of us have a pain at some point. When do you have to start taking it seriously?
Yeah, so the knee, I would say, it tends to cause a lot more pain that's noticeable, or people notice that pain. A lot of times when you're really noticing that you need to maybe go in, that's when you start to maybe even get some of those secondary symptoms like swelling in the knee. You may hear a lot more, what we call crepitus or clicking and popping when you bend it. In certain situations too, you can have it where you bend the knee and then it catches on you, or you have trouble extending it or bending it.
Okay, those are all signs where you should start to think, I need to see somebody about this.
Yeah, definitely.
Now, obviously, the whole kind of point of this podcast is to talk about, because you're a surgeon, so you go in and you want to fix it. If you can, surgically, right? But we were talking a little bit before the podcast started about ways to do this where surgery isn't necessary. Is that? There's lots of therapies that you can do for stuff like this, but at a point where a knee or a hip needs to be replaced, are there still options that people can take so maybe they don't have to?
Yeah, so there are a couple different ways that you can treat the pain that you're having. Some of those options are treating it with non-steroidal anti-inflammatories, activity modifications. There are some injections like steroid injections and sometimes PRP or hyaluronic acid, especially in the knee, that people will try. However, when it becomes really arthritic and there's bone spurs, there's not necessarily an option to change those bone spurs or loss of cartilage without replacing the hip. Now, if we're able to catch it maybe before and you're having pain, but you don't have complete arthritis, then there's also a whole other range of surgical procedures that we can do that are a little bit less invasive, that we can hopefully do to, one, help cure your pain, and two, can also help prevent arthritis progressing to where it becomes you need a joint replacement.
What is arthritis, doctor? Just in simple terms, what is it?
Yeah, so arthritis in simple terms is that the cartilage which covers your bones in the joints has worn out, and it can either wear out kind of mechanically from wear and tear, and that's what we call osteoarthritis. The other is if you have autoimmune symptoms or an autoimmune syndrome, that can also cause the cartilage to become worn out, and that's what we call an inflammatory arthritis. But arthritis is just the wear and degradation of the cartilage that covers your joints.
And is that mainly why then you need that replacement, is because those joints are going bad? Is that what it is generally?
Yeah, so generally the reason why we do joint replacements is that at least as of today, there are no great alternatives for replacing large amounts of cartilage. If you have a small cartilage injury, there are some surgeries that we can do to kind of help put new cartilage in that can regrow, but we can't regrow cartilage
on a large scale. Scale. Well, how big then? Because now I want to know how big the cartilage is. How what's the size of it in like a hip? Is it? Explain cartilage to me first. Let's go there.
Yeah.
And I want to know how big this is.
Yeah, so cartilage is it's a surface that goes over the top of your joints.
Okay.
Over the hip. It can be in the knee as well. It goes over the femur and tibia and the knee, and in all of your joints. It's there. It's not very, very thick, and it is a surface that is. I actually tell my patients it's a surface that the coefficient of friction, which is it sliding on itself, is less than ice on ice. So it's a very slippery surface.
Wow.
It's made of collagen, which is kind of the things that you see in gristle or,
Right.
in animal products. And it also has a bunch of water. And so it provides a couple different things. It allows the bones to slide across very friction-free. And then it also provides a little bit of cushioning.
Okay. So it's important, obviously.
Yeah, it's very important.
You need it.
Yes.
But it can be regrown, you've said.
So
to a point.
To a point. So
Okay.
for what we call smaller defects, and those are, several centimeters across. And those smaller defects, we can do some procedures to replace portions of that cartilage. And there are ways that you can harvest a little bit of that cartilage, grow it in a petri dish, and then come back and insert it in that area there where the cartilage is damaged or destroyed. You can also take parts of a cadaver and put that in to either the hip or knee to replace a cartilage defect as well.
Okay.
And we do that particularly for younger patients who may have a isolated injury to their cartilage. But when it becomes global or you have pretty extensive cartilage damage, especially with the hip, it's much better to just replace the hip. And part of that is that the outcomes with the hip replacement at this point are really, really good. And,
are they really?
Most people do really well. And so when we look at our large-scale registries, we see satisfaction rates for a hip replacement at 98% or even better. So it's one of the best performing kind of surgeries that there is in medicine.
How does the knee fall into that? What's like the outcomes for that?
Yeah, so the outcomes for the knee are also really good. It's probably, in the spectrum of things, still also one of those kind of top 5 surgical procedures in medicine. It's about 87% to 85% if we look at the registries. So it is a little bit lower than a hip replacement. It tends to have a kind of a little bit of a harder recovery, and it's a little bit more sensitive to your range of motion and getting your range of motion back.
Okay.
But if you get those things, there also has a pretty high success rate as well.
I've heard and talked to people that have had knee specific, and they do say that it is a kind of a painful recovery.
Yes.
Why is it? Is the knee? Is there more movement in your knee than there is in your hip? Generally.
Yeah. So so when we do the knee replacement, it does require for us to kind of split a little bit of the tendon, and it is a little bit more invasive of a procedure in some respects than a hip replacement. I think the other thing is that the anatomy of the knee, it depends a lot on the ligaments to help stabilize it once we've replaced that knee.
Mm-hmm.
Where with a hip, it's a ball and socket joint. It's a very stable knee, regardless of additional ligaments.
Yeah.
And so we don't tend to have the same issues with stiffness that we do with a knee, and we also don't. And because of that, we don't have to push you through trying to get that range of motion
Right.
like we do with the knee replacement.
Well, I suppose it's that physical therapy afterwards too, though, for your knee.
Yes.
I mean, if you've cut into any part of your body and now you've got to go stand next to somebody that says move it.
Yes. Yes.
That's not going to feel great for a
Yes.
while, for sure. So what are some of like the biggest improvements that patients feel afterwards once it's successful?
Yeah. So for most joint replacements, they're all very similar. I think the number one thing that you should notice is a reduction in pain. The other thing, especially for a hip replacement, is that you should notice an improved range of motion. If you had a limp, hopefully that is no longer, that is restored, and you have a normal gait once you've had your hip replaced. Similar with a knee as well. It should help your pain first and foremost. And then also you should have some improvement in function. I will say with the knee replacement, that function may be a little bit different because a lot of times with knees, they do have some issues with stiffness occasionally. And that stiffness can be residual, meaning that if you came in to surgery with a pretty stiff knee or a loss of range of motion, we're usually able to improve it, but maybe not to the level of when you were 8 years old or a kid.
Is there things we can do right now though to make sure we don't ever end up in that situation if it's not something that's genetic? Are there things that you wish people would know? Hey, do these things, and then you don't have to see me, sort of a deal.
Yeah, so some of it is wear and tear, and that is not necessarily fully preventable. We want you to be able to enjoy your quality of life, and that may come at the expense of some of your cartilage, but I don't think it should limit your activities. I do think that one thing that I do wish people would do is, especially for those who enjoy going out on long walks or runs and hikes, is to be conscious of the surface that you go on those runs or hikes on. And in particular, we know that concrete is a very stiff surface. And so, doing lots of running on hard concrete, I think is something that I tend to tell my patients to try to avoid, especially if they're already having pain.
Yeah.
And try to stick to some softer surfaces. And so we even see with, marathon runners in particular, that they also do a lot of picking and choosing the surfaces that they train on. Right. And that kind of helps them to, do the 100 miles or 200 miles a week that they're able to run. And I think we can learn from that similarly. And so even though we may not be doing nearly as many miles as them, we can still, because just our cartilage is a little bit nowhere near as good as their cartilage, that we can try to stick to, surfaces that are a little bit friendlier on the joints.
Is there sports in particular? Now, like you said, you ski and you climb. And you do those are strenuous sports, really. What sport, in your opinion, is just the hardest on knees and hips?
I think that all sports, I wouldn't discourage anyone from doing any sport.
Of course, absolutely.
I will say that as first. I play college tennis, and so I am a tennis player. But I do think that, in particular, a lot of the court sports and even sports such as like pickleball and tennis, they can be quite hard on your joints, especially because we don't have a lot of soft surfaces for the racket sports that we play. And so, in Europe, they do have clay courts and, grass courts, which are softer. But when you're doing a lot of those cutting motions on a hard court, we have been seeing, especially with, something like pickleball, which is becoming a
big deal, especially for older people. Lots of older people are playing it.
And we're seeing a lot of injuries starting to creep up from that. And I think that a lot of that is, like I said, it's the hard surface, and a lot of those cutting sports can be hard on the knees as well as the hips. That being said, there is a lot of benefits from being active, and if that's the activity that gets you out and makes you active, I would still suggest you keep up with it.
Obviously, I'm surprised you didn't say a contact sport, like obviously football or hockey, any of those where you're just constantly moving and getting slammed into at the same time. Are there Are there exciting things down the line that you think is really going to kind of change up how you do your job when it comes to replacements and telling people, hey, this is what you should do, less invasive things? Do you see it change pretty frequently?
So it has been changing a lot. And in particular, I would say we've kind of really started to make a big transition, especially in hips, with what we call anterior approach surgeries. And so that's an incision that we do in the front. It's a muscle sparing, and I think that's really the key, is that we don't cut any muscles when we do the approach from that way. And we see that the recovery is slightly faster with that approach when we study it. And then there's a slightly lower dislocation rate also with the approach. And so those are two things that definitely I think are benefits to doing that. And a lot of patients are actually returning back to activity levels at quite astonishing rates. I've had patients that have come back at their 2-week visit after having their hip replaced, and they're running in place.
You're kidding.
So it is definitely something that I think is really starting to become much more popular, I think. And then we've looked at some surveys, and nationally, especially among younger surgeons, it's the rate is somewhere closer to 60 to 70% of surgeons are starting to do that approach.
Yeah.
So
why? Okay, this might, I don't know if you can answer this question, but it just popped in my head as you're mentioning this. Because I usually will ask a lot of doctors on the podcast about new technologies that are coming out, and sometimes, like you said, there's just new ways to do the procedure. Why wasn't the procedure done that way to begin with?
Yeah, so
I don't like I said, I don't know if you can answer that, but I'm thinking, well, wait a minute.
Yeah, for this one, I can actually.
Really?
My background is that I actually did research for studying the anterior approach surgery. Probably about 15, 20 years ago.
Oh, wow.
So I was a research coordinator kind of doing these original studies of looking how fast people restore their gait.
Have you ever not looked at a medical book or just a research book at all? Have you ever, do you read anything else for fun?
Yes.
Okay, good. Maybe not?
Maybe.
All right.
I do enjoy, reading some climbing stuff. So
of course.
I do find some time to do
awesome.
some recreational stuff. But so the way that it actually started and hip replacements in general were from the posterior approach. And so that was the first technique, and that technique had great results. And so that was the reason why people started to do it from the posterior approach. And then quite some time later, some people started trying to do it from other ways. And so actually in France is where they really kind of first started doing the anterior approach quite a long time ago. And then here, kind of independently of France, kind of early in the 70s, we started also doing an anterior approach as well. Kind of with the way that the French had did it is they needed a special table. And so not having access to that special table, that kind of delayed a lot of surgeons adopting it. Here in America, a surgeon did finally come up with a way to do it without the use of that special table. But it really just took a lot to kind of popularize, especially because it is a slightly more technical procedure.
Sure, of course. But as the equipment gets better and the technology gets
Exactly.
better, then you'll continue to see those kind of improvements.
Yeah.
Really, there's no muscle up on the front part of your groin there.
So there are muscles there.
Right.
And so all of our muscles are contained within a sheath, which we call the fascia, and that surrounds those muscles.
Oh.
And so in the back, there's a big muscle. We all know
of course.
the gluteus
Yep.
maximus.
Right.
And the only way to get there from the back is to split that muscle. And then there are muscles that also attach onto the back of the hip joint as well. And the only way to get through those is to cut those off. Now, we repair them on the way out, but it does take a little bit more time to recover because you have to let those muscles heal.
Yeah.
In the front, we actually retract muscles and kind of go right in between all the different muscles. And so we, push them to the side, and they're still in their fascial compartments, and we can push them to the side and get direct access to the hip without cutting any of those muscles.
Oh, it is amazing. I want to be around in another 20, 30 years. I just love watching the technology change in medicine and how quickly it seems like, even from when you started to now, you have to look back and be like, wow, right?
Yeah.
Look at where we've come.
Yeah. For me, doing research in this area, 15 years ago and now seeing where it is, it's quite amazing, especially because when I started, patients were still in the hospital with a hip replacement for several days. We would do dressing changes, and we would see them, one day we'd do the dressing change, and another day we would pull their drain, and then we would see them on another day, and then finally we would get them out of the hospital, and a lot of them had trapezes, which are little things that hang down from the bed so they could try to pull themselves up, and they wouldn't get out of the bed much at all. And now patients are within an hour or two of having surgery walking down the hallways as I'm seeing my other patients that I'm getting ready to operate on.
Turning around being like, just hold on, wait. Lay down for a second. I got to get back to you.
So that has been a cool change.
Are there as we kind of wrap things up here, Doctor, are there any myths about this that you wish people would stop believing? Do you ever have to tell people, look, that's not true. That's just not how this works. Is there anything you would like to tell listeners now to just kind of allay their fears a little bit about coming in to have something like this done?
Yeah, so I think probably the biggest one that people are worried about is the implants wearing out, and only having a 15 years or 10 years or 20 years, and then they need to have a replacement or a second surgery. And what I would say is that we've also really improved the technology in the components that we've used. Not so much that we have new technology. In the 2000s, we pretty much had most of the technology that we have, but we tried multiple different things, and some of those things didn't work out very well, and they resulted in some recalls and things like that. Now we've really kind of selected the winners of those groups of the technology that we were trying in the 2000s, and what we found is that the new plastic, which is and we didn't really cover this, but a hip replacement.
You can feel free to go into it for sure.
Has a couple of different parts to it. Part of it is titanium, and that's the parts that go into the bone. But the part that moves, that is a combination of ceramic and plastic. And so the ceramic is rubbing on that plastic. And that surface performs very, very well. About 10,000 times better than the traditional or older plastic that we used to have. And so that really has put into question how long these implants will last. I think that's probably the best way to think about it. I don't think that, we don't know exactly how long, because we don't have necessarily that 20 or 30 or even 50-year data to know that these will last for 50 years. But there is even some early data, 30 years, 100% intact in young patients. And I don't think that, implants wearing out is going to be much of an issue, especially on the hip side. But even on the knee side, the same plastic is utilized, and I think that it will also last much longer. We just don't know how long these will last. But there is no point that we ever have to just take you back, even though it's fine, and take out your implant. We only will take you back if there's a problem or something happens. And nowadays, we're seeing that the plastic wearing out is not necessarily as big of an issue as it used to be. And really now it's either you breaking your hip or breaking your bones, which you can always end up doing, or infection. And that would be the other reason that we're kind of taking patients back to revise the implants.
What's kind of the age range for a hip replacement or a knee replacement generally for the best, most successful outcome?
Yeah. So I would say that really advanced arthritis is probably the biggest requirement. And I think that patients who have pretty advanced arthritis are going to do well with the hip replacement regardless of age. If the patients are really young and they have arthritis, meaning maybe they're in their 30s or 40s, especially with the knee, we may be a little bit more concerned with, wear and tear of the implant over time. With a hip, that is an implant that performs really, really well.
Really?
And I'm not sure that we necessarily have an age cutoff that it works best on. Obviously the younger the patient, sometimes there's things that we can do to save or prevent, doing a hip replacement, especially if they're 18 or 20. And so that's a whole nother area that we do. And I also do a lot of research and do those procedures as well to try to save the hip if it can be saved,
right,
for those younger patients who are maybe less than 30 but are having a lot of hip pain.
I got it.
So.
Okay. Well, if anybody's worried about not enough research being done, you are not the guy to talk to, because it sounds like you have done all of the research on this. So this is fantastic. It's been a lot of fun to talk to you, Doctor. And I know we want to have you back again to talk a little bit more. We can touch on a little bit more of this too, and just kind of general. I believe we want to talk a little bit about joint replacement as well, don't we? Kind of tie into that a little bit.
Yeah, so hip and knee replacements are forms of joint replacements, but I think that there's just we could definitely talk a lot more about the expanded indications of joint replacements and also some of the other joint replacements, including shoulder replacements,
Sure,
which my partner Dr. Woodard does.
Okay.
And so that would be a great one to discuss.
Well, let's get him on the podcast then too, for sure.
Yeah.
And we'll let you guys go.
All right.
Dr. Kenneth Milligan, an orthopedic surgeon at Monument Health. Thank you for coming in and talking to me, Doctor. And anytime you want to discuss, we should talk about maybe physics next time.
Yes.
If you want to come in. And you got way too excited for that. I was half joking. I'm just, but if you want to, we will. All right. Thank you, Doctor. I appreciate you coming in.
All right. Thanks.